Good morning, everyone. Well, I hope you have enjoyed the content that you've experienced this morning at CareOregon's Meds Ed as much as we've enjoyed bringing it to you. We have been extremely fortunate to have three wonderful local presenters here with us today to share their expertise on this topic. And we're even more fortunate to have them all gathered together here for this special live chat feature of our Meds Ed, where we're able to respond to some of the questions that you've had this morning. We've had three different segments for you from Dr. Gillespie, from Dr. Spiro, and from Dr. Cheng. And during those different segments this morning, folks have weighed in and asked some questions via the chat feature here today, which we've collated. And I think people are still submitting chat questions as we go. So we'd like to just take a few minutes while we have the panel gathered together live in our chat feature here on Microsoft Teams, and we'll be able to answer some of those questions. If that sounds good, I'm going to go ahead and ask a few of these questions here right now. Probably going to go a little bit in order here. We had quite a few questions that came in here during the initial segment for Dr. Gillespie, so I'd like to throw a couple of these at you here, Doctor, if I could. The first one is, what social emotional screening tools are you or behaviorists using for the baby young toddler when a parent screens positive for ACEs?
Sure. So we're using the ASQ social emotional tool. So the thing to know about ages and stages questionnaires is that the general developmental questionnaire isn't very strong in measuring the social emotional domain. So even though the regular developmental screen contains that section, the ASQ SE or social emotional version is meant to go a little bit more in depth in that. And so that's the tool that we're using. Each of the tools are tailored for different ages. So when you buy the system, you get a number of different screening tools that are appropriate for the different ages through age 5, I believe.
Excellent, excellent. And then I had another follow-up question on here as well that I think is interesting. An additional question is, what information and also how much information are you sharing with some of the community referral sources? And ones they mentioned here are like HMG, early intervention, even PT and OT, about parent ACEs experiences and its role in the child's current needs.
Well, the simple answer is that we're not disclosing that at all to the community resources, because I think that when it comes to parent ACEs and what they've chosen to disclose to me, that doesn't imply that they've chosen to disclose that to anybody else. And so if I'm referring to a community agency, for example, Help Me Grow, usually it's because the parents have identified a specific community resource that they're interested in. For example, if they're interested in parenting classes, or if they're interested in support groups or developmental supports and ideas about how to stimulate their kids' development, then that's the information that I give to Help Me Grow. And that leaves it up to the family to decide whether or not they disclose that information to their intake worker or not. Certainly Help Me Grow is aware that I'm doing the screening, and they're aware that some of the referrals may be based on having discovered a history of parental ACEs, but it is ultimately the parent's choice whether or not they're going to disclose that information. And that relates back to even how we document parent ACEs in our medical record. We created a field within the electronic health record that is a confidential field, so that the information will pop up when I have a visit open, but it doesn't print into notes. And the whole concept behind that was to protect parent privacy again, so that any disclosure is up to them. So if I send notes to a specialist, for example, or if I send notes to another provider, if the family moves to a different clinic, then none of that information about parent ACEs actually gets shared. Because I think it really is the parent's decision whether they disclose. And certainly parents have to know that they can trust the person they're disclosing to. And so, me choosing to disclose on their behalf to someone that they don't know, I think actually creates a barrier to completing the referral. And so frankly, I don't disclose any of that information. If a parent said that they wanted me to, certainly that would be a different situation altogether, but I do feel it's very strongly that it is the parent's choice ultimately.
connects for me with a lot of what you said in your segment, where you're talking about how the important thing is like to have that relationship in order for there to be enough trust for somebody to start opening up about things like that.
Absolutely. And to me, I think that's always success in those conversations is not so much, is there a disclosure or not, right? It's never my goal to force a disclosure out of a family, for example. So I'm not as interested in the result on a screening tool as I am in whether or not I've built that relationship to a point that a family can trust me to guard their confidence and to support them and to partner with them in their journey as parents. I think that part of the way that's played out for me is that for all the years that I've been doing these assessment tools, I've had dozens of times where at some subsequent visit, a parent will disclose something else to me that's sensitive, but that they know that they can come to me. So I've had probably 15 moms in the last 6 or 7 years that have disclosed domestic violence to me. I've had many parents who've disclosed financial problems, family losses, food insecurity, other things like that, because I've spent the time on the relationship. So again, to me, the goal isn't to just find out if parents have ACEs or not. The goal is to build that trusting relationship so that when there are other issues that come up in their lives, which will ultimately happen, they know that they have a safe place to come and have those issues addressed. And I have never pretended to have all of the answers for any of those things that have come up, but I have promised that I will figure out how to get them the support they need. So if it's not something that I can provide myself, then the families know that I will figure out where to connect them to get what they need.
Excellent. I mean, I could expand on that question a bit to all of the panelists here today. I mean, don't you feel like, in general, that when patients feel that somebody gets them and understands them from an individual basis, that like it's like you understand who I am and what it is that I've gone through, or what they've confided to you, that there's a greater likelihood of there being engagement that lasts and hopefully forward momentum towards the goals you're trying to achieve with them?
I'll just add that absolutely, yes. I think that a trusting relationship is the cornerstone to getting families the help that they need, and having them feel comfortable in sharing with you and knowing that they won't be judged. And I think that also comes from an approach where you go into each interaction with some basic assumptions. And those assumptions are that kind of everyone's doing the best that they can, and that if things aren't going as you're hoping or as expected, or if folks aren't following through with things, or if folks are struggling, that there are legitimate reasons for those struggles, and to approach in a caring and compassionate way to try to understand what those things are. So I think always moving forward with those assumptions, it helps your perspective when you're interacting with families, and I think that it's sort of that kind of lens lends itself well to building a trusting relationship.
Yeah, I found it very moving, frankly, when you talk towards the end of your segment about just the perspective that you have and that works best for engaging with patients, especially when you use the smart rats example of just presuming that somebody can overcome something. I think that was just really powerful for me, and I think people really seem like they related to that.
Yeah, I mean, I'll also say when families are dealing with a lot of social vulnerabilities, and when there are these intergenerational cycles of trauma and social struggles, I really think that building trust is really challenging, and I think that families, especially caregivers, they don't believe in themselves. So I think that their sense of self-worth, I think a lot of messages that families get are just, even from well-intentioned people, can be perceived as judgmental. And I think when you've grown up in hard situations and it's affected your self-esteem, and then you become a parent who also feels like you're not being very successful and effective. I mean, our model in NICH is that kind of we believe in you until you believe in yourself. And so not only do we move forward with a lot of, again, those assumptions of assuming everyone's doing the best they can and their barriers are legitimate, but also, that we believe in you and that we know that you're doing the best you can.
That's powerful.
I think when it comes to trauma disclosures within practice, I think there are a couple of mistakes that providers tend to make. One is they expect that they're going to go into that particular encounter and fix everything right then. And I don't think that's reasonable. I think it's important to focus on what it is the family needs at that exact moment, trusting that you're going to have that longitudinal relationship that you will be able to pick up the other pieces over time. And so I think one of the fears that people have when it comes to should I screen for trauma in my practice is that they're going to have this massive overload of stuff to do, and it's going to disrupt their visits and it's going to disrupt their flow. But I would say that more often the person in the room who is changed by the disclosure is me. That rather than me coming in with an aggressive agenda about this is what we're doing today at our well visit, I'm spending the time understanding where the family's coming from so that I can know what their priorities are, and so that they can come to me with these are the things that I need to nail down before I can address these other bigger things that you want to talk about. You know, we all go into our well visits in particular with a long list of things that we're supposed to counsel about, whether that's car seats or gun safety or making sure you're using a bike helmet or whatever. And if a family is not ready to receive that information because of something else that's going on, then you've already lost the visit, right? Like you're already not going to reach that family. I can think of one case in particular where I went in to a visit with a 4-year-old, and you know, when I got to talking about behavior, the mom started talking about how every time she tried to discipline the child or correct a behavior, that he would immediately kind of giggle. And as she's describing it, I mean, I thought it was kind of cute because I sort of figured that was normal stuff for a 4-year-old. But as she's describing this, she starts turning beet red and the veins start sticking out of her neck and her forehead. And I had to take a minute to say, what does that mean to you? Like, what does it mean if somebody's laughing at you? And going through that history, she had been humiliated and verbally abused as a child. And so she interpreted her kid's behavior as something that her abuser used to do, right? And so if I'd gone into that visit and just said, here's what you're going to do to correct kids' behavior, and here's how discipline is done at this age, and blah, 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 none of that would have been received by the mom, right? And so when I heard her history and I was able to understand what that behavior meant to her, as soon as I asked her, why do you think he's laughing? And she talked about how humiliating and frustrating it was. I asked her, well, do you think maybe he's embarrassed and that his natural reaction is to giggle when he's embarrassed? And her face kind of dropped, and she'd never really thought about developmentally where that kid was, right? And so when I was able to kind of see what the behavior meant to her and relate that to her experience, then I was able to counsel her in a way that was a little bit more effective. But more importantly, at the next visit, when she came in, I came into the room, I said, you know, good morning, how are you doing? And she said, you know, I'm thinking about what you said last time, and that's all super interesting. But in the last couple months, my husband lost his job and we're struggling to get food on the table. My mom, who is my primary support network, passed away, and I'm struggling right now. And to me, it was an amazing visit because we've had so many encounters with our patients. All of us have had this where we know there's some underlying issue that is driving the behavior, but we don't get to the crux of what's really frustrating or upsetting to parents. And so we don't know why they're not listening to us a lot of the times. But once we create that trusting relationship, then we're able to have a family come to us and say, these are the things that I need today. And so then we started talking about, you know, financial assistance and food pantries and things, which really was more important in that particular moment than following up on how the behavior was going, right? And so I think that again, what changed was not so much the mom, because she knew what had happened to her and she knew her trauma history. What changed was me, is because I went into the rooms expecting to need to learn something from her and to need to relate to her in a way that I wouldn't have done if I hadn't bothered to get the history.
Wow. This, of course, makes me wonder to what degree all of you employ some use of motivational interviewing in your interactions with folks? I'm guessing a lot, because a lot of what you just shared with us reminds me of those basic principles. The idea that the patient is the best expert on their own individual circumstances, and the fact that you can't expect to do everything in one encounter, that it's obviously going to take more time spread out across the course of the relationship with the patient to really get somewhere. Does that seem fair?
Yeah, I mean, I would say for sure motivational interviewing is an important skill, but I think that what you were just highlighting there was actually slowing down and really being a good observer of the interaction and the parent's reaction around something, and then actually being sensitive to what the parent's experience was in that moment. And I think that's the key to that, is actually slowing down and reading the cues from the folks that you're in the room with. I don't know for sure. I'm not a pediatrician, but it sounds like that's kind of what you did, is and then being comfortable asking about someone's experience in that moment. Like, share with me what's going on for you right now, and how does that make you feel, kind of questions, which is a little different than motivational interviewing, but I think it does open the door to have people know that you're caring and interested in what they're feeling and what their experience is in the moment.
And I do think that motivational interviewing involves a little bit of a change in mindset. So, one of the phrases that I talked about earlier that struck me in motivational interviewing is the idea of abandoning the righting reflex, that we're trained to just fix whatever's in front of us. And a lot of times, if we're leaning on that training, then we're not being mentally present to actually observe those changes in a person's demeanor or behavior, or to ask those questions about what a behavior means, because we're going in with, we're going to fix this, and this is how it's going to go. And it's a very one-way interaction. And I think that gets in the way of being present for what's actually going on in the room right in front of your eyes sometimes.
Wonderful, wonderful.
RJ, what I like to say is what you're doing is showing me that pediatricians can do psychotherapy too. One of the things we struggle with in OPAL-K is to convince people that they can be very psychotherapeutic. And, before you even get to motivational interviewing, just listening empathically is therapeutic. And I think that most primary care clinicians have that kind of intuition about doing that. And then, what we say technically, the way into engagement is validating the patient's parent where they're at the time, and listening and trying to say, I can understand how you would feel that way. And once they feel validated, then that engagement increases, and they'll feel more comfortable talking about what's going on.
Excellent. I want to be mindful of our time, because I know we're getting near the bottom half of the hour, but I did want to just sort of segue into a couple more questions before we call it a day here today, friends. But let me ask you this. A couple folks asked questions along the lines of resources and opportunities during the visits to convey these things. In terms of like curriculum that you talk about, like things like parental self-care, circle of support, is that just usually more of a face-to-face conversation? Or are there a lot of other handouts that you rely on to give to resources as a family? I know, Dr. Cheng, you focused on a lot of different resources that you have at your disposal there, but I certainly would love to hear from everyone. What are some of those things beyond the face-to-face conversations that you pull from?
So at OPAL-K, we have quite a number of primary care clinicians calling in about their families who are struggling with being sheltered at home because of the COVID pandemic. And, it's a new world for them. They're not used to staying with their kids, 24 hours a day. There's no school to provide respite for the parents. So those troubles come to the primary care office. And, the nice thing about OPAL-K is we can talk about the cases individually, but we do refer parents to or the primary cares to websites that meet their needs. So, for example, the Massachusetts Psychiatric Access Program, they have handouts that can be downloaded from their website, and we would refer a primary care clinician to that. Or we can just go over, just basics that we all talk about, trying to survive, kids at home, providing structure and a schedule, setting up goals to be accomplished for the day or the week or the month, and then, trying to make sure that you're not isolated and connected, and who can you communicate with in your community. So that would be one example of how to do that from OPAL-K.
Excellent. And then one last question here, and this is kind of a little bit of a segue, but it's a big topic, and I know it's on everyone's mind here lately, but this was addressed to all of you as presenters here today. If you could speak a little about what you might be aware of in terms of available mental health services for parents during the current pandemic. This person expressed that they work at a family homeless shelter in Portland, and that all the added stress of the new guidance that they've had to take on has had a real dramatic effect on the emotional stability of parents and also child behavior. They want to be able to offer counseling as folks are having so much anxiety about talking about this with their primary care providers. What are your thoughts?
Well, I'll go. One of the things we frequently do is hook up parents with 211. So those are experts at connecting to what they think fits the parenting or family situation. So that's one place anybody can call to get referrals to, to care. I think the other thing is that, depending on the insurance, they can call their insurance company. And I know at CareOregon, where I work, we have care coordinators that can hook up supports for these families. So that would be another avenue for support.
And I would just call out that for the kids under the age of 5, Help Me Grow is a resource that would help with some parent stress and also helping with tips about how to deal with child behavior. They have worked through some workflows that relate to the COVID pandemic and how to help support families. I think that one of the conversations we've been having back office is that COVID has really uncovered that social determinants of health are everywhere. And right now, the social determinant of the day is internet connectivity. And so I think a lot of families are really cut off from getting mental health support if they can't get access to a device that will do a virtual visit, for example. Certainly our behavioral health providers within our office are doing all of their visits virtually, but in terms of community supports, I think that Help Me Grow is probably one of the places to look for the early childhood supports at any rate.
Wonderful.
And while this also requires internet connectivity and some kind of tech device, the American Academy of Pediatrics, they have a number of links on their website specifically for supporting parents and kids during this time.
That's excellent. It's always good to know there's a whole community beyond the immediate things we see that's out there that we can call on, especially now. But speaking of community, I know that we all have to get back out into our lives here today and return to our practices and everything else that we have on deck. So I just want to take a moment to join all of our participants who logged in to share this content today. Our deepest thanks to all three of you for coming together and sharing your insights and your perspective and your caring to such a huge degree in the amount of time to put this together. We're so grateful for your participation and for what you were able to share with us today. I know it's going to make a huge difference in the lives of many children and their families in the Pacific Northwest area. So thank you for that. I think we should let these guys get back to their extremely busy practices. So thank you all three again. And for those of you who are still on the line as guests here today, just want to walk you through some final things in terms of housekeeping, so you know about your CME and know about what's coming next in the Meds Ed program. Shortly on screen here today, you're going to see a slide that does have a web address on there for a SurveyMonkey survey that we're going to be pushing out to you this afternoon. As you just record your name, your designations, and answer some real brief evaluation questions about the content that you experienced today. That way we can have you properly recorded as being attendees so we can get you your CME credit. If you have difficulty accessing that survey, or if you don't receive an email from us today, just shoot me an email directly, Carson P. for Paul at CareOregon.org, and I'll make sure you get a copy of that link, because we want everyone to get credit for what they experienced and for the time you spent today. In probably a little bit more than a week or so, we will have this video posted on our MedsEd webpage, so it'll be able to distribute to folks who weren't able to come today, and we can share that throughout all the different coordinated care organization environments. So this will be preserved and have a good, long-lasting chance to be seen by people who weren't here with us today as well. Lastly, if you would just mark your calendars for June 18th, also a Thursday, our next MedsEd is going to be focusing on alcohol use disorder, and we've got a phenomenal panel of folks coming together to provide some great insights and best practices on how folks can make a difference for patients involving alcohol use disorder in primary care and beyond. A lot of our focus seems to get put towards opioids these days, and the alcohol use syndrome has just not been going anywhere. And so there's still a huge need to make sure that it gets the focus and attention that it deserves. So I think you're going to find this is an excellent, excellent program that we're putting together for you right now. If you have any questions about that, you can access that through Eventbrite, or I can send you the link to enroll directly as well. I think that's about all we have time for here today, friends. So I'd like to just again thank all of our presenters, Dr. Gillespie, Dr. Spiro, Dr. Cheng, and to thank everyone at CareOregon, and a special thank you to our communications and IT folks who came together to help make this such a success this week. You guys have done a phenomenal job. And to our attendees, thank you for everything that you do out there in the greater Pacific Northwest to care for so many people who are dependent on your heart and your skills. We greatly appreciate you. I look forward to seeing you next month. And in the meantime, stay safe out there and look out for each other. And we'll be back together in a non-virtual way, hopefully sooner as opposed to later. But in the meantime, take care and stay well. Thank you.